The gastrointestinal system is one continuous muscular tube, roughly 9 meters long, running from your mouth all the way to your anus. But don't let that simplicity fool you. This single tube is one of the most heavily tested systems on every major medical licensing exam because it ties together anatomy, physiology, biochemistry, and clinical pathology into one seamless story. Picture it as a factory line. The mouth and esophagus are the conveyor belt. The stomach is the acid grinding station. The small intestine is the absorption warehouse. And the liver, gallbladder, and pancreas are the support utilities, feeding enzymes and bile into the line at exactly the right point. 4 accessory organs, the salivary glands, liver, gallbladder, and pancreas, never touch the food directly, yet without their secretions, digestion simply collapses. Throughout this video, we're going to trace that journey from mouth to anus, connecting structure to function to clinical disease, because that is exactly how board examiners think. They don't ask you to memorize isolated facts, they ask you to follow the mechanism. So buckle in, because by the end of this video, you'll see the GI tract not as a list of organs, but as one elegant, interconnected machine. Let's get started. Every part of your gut, from esophagus to rectum, shares the exact same 4-layer architecture, and this is one of the most reliable patterns in all of GI medicine. Starting from the inside out, the mucosa, made of epithelium, lamina propria, and a thin muscle layer called the muscularis mucosae. Then the submucosa, packed with blood vessels and home to Meissner's plexus, which fine-tunes secretion and local blood flow. Then the muscularis externa, with an inner circular layer and an outer longitudinal layer sandwiching Auerbach's plexus, the engine that drives motility. And finally, the serosa or adventitia on the outside. Here's a detail examiners love. The stomach breaks the rule. It adds a 3rd innermost oblique muscle layer because solid food needs to be churned and ground, not just pushed along like a liquid. Miss that exception and you'll miss easy points. And remember, these 2 nerve networks, Meissner's and Auerbach's, together form what's often called the gut's second brain, capable of coordinating digestion even when disconnected from the spinal cord. When this network fails, disease follows. Lose Auerbach's plexus in the esophagus, and you get achalasia. Lose it in the distal colon, and you get Hirschsprung disease. Structure truly is destiny in the gut wall. 2 territorial maps are absolutely essential for board success, and the first is the retroperitoneal compartment. Use the mnemonic SAD-pucker, suprarenal glands, aorta and IVC, duodenum, specifically its 2nd through 4th parts, pancreas, except the tail, ureters, colon, the ascending and descending portions only, kidneys, esophagus, and rectum. Everything else hangs freely in the peritoneal cavity, suspended by mesentery. The second map is vascular, and it follows embryology beautifully. The celiac trunk supplies the foregut, from the lower esophagus down to the 2nd part of the duodenum, along with the liver, spleen, and pancreas. The superior mesenteric artery supplies the midgut, from the 3rd part of the duodenum through to the midpoint of the transverse colon. The inferior mesenteric artery supplies the hindgut, from there down to the upper rectum. Now, here's the high-yield danger zone. The marginal artery of Drummond connects the SMA and IMA territories, but the connection is often poor at 2 watershed points, the splenic flexure and the sigmoid colon. During hypotension, cardiac surgery, or shock, these 2 zones are starved first, producing ischemic colitis. If a question describes left-sided abdominal pain with bloody diarrhea after a hypotensive episode, your mind should jump straight to these watershed zones. Your gut has its own nervous system capable of functioning almost completely independently of your brain, and it contains over 100 million neurons, more than your entire spinal cord. This enteric nervous system has 2 working components. Auerbach's myenteric plexus is the motility engine, sitting between the circular and longitudinal muscle layers, driving peristalsis, using excitatory transmitters like acetylcholine and substance P, balanced against inhibitory transmitters like nitric oxide and VIP. Meissner's submucosal plexus is the secretion engine, regulating mucosal glands and local blood flow. Both plexuses receive autonomic input. Parasympathetic fibers via the vagus and pelvic nerves are excitatory, ramping up motility and secretion, while sympathetic splanchnic fibers are inhibitory, slowing things down, which is exactly why stress and surgery commonly trigger constipation or ileus. Now for the board-defining concept, pathological absence of ganglion cells. In the distal colon, this absence causes Hirschsprung disease. The affected segment stays tonically contracted, creating a functional obstruction in infants, diagnosed by rectal suction biopsy showing absent ganglion cells. In the esophagus, the same loss of Auerbach's plexus causes achalasia, producing that unmistakable bird beak sign on barium swallow as the lower esophageal sphincter fails to relax. Same mechanism, two completely different diseases, depending on location. Inside your stomach lining sits a remarkable cellular machine, the parietal cell, built almost entirely around a single pump, the hydrogen-potassium ATPase, which fires hydrogen ions into the gastric lumen in exchange for potassium. This pump is irreversibly blocked by proton pump inhibitors like omeprazole, which is exactly why PPIs are so much more potent than older drugs. 3 accelerators drive this pump. Gastrin, acting through CCKB receptors, ramps up acid production and is the single most potent physiological stimulant. Histamine, acting through H2 receptors, is the target blocked by drugs like ranitidine and famotidine. And acetylcholine, acting through M3 receptors, completes the trio. Crucially, these 3 pathways potentiate each other, which is precisely why a PPI, blocking the final common pump, outperforms blocking any single upstream signal. On the other side, 2 brakes keep acid in check. Somatostatin from D cells is the universal inhibitor, while prostaglandins protect the mucosa directly, which is exactly why NSAIDs, by blocking prostaglandin synthesis, cause ulcers. The ultimate exam case here is Zollinger-Ellison syndrome, a gastrinoma driving unchecked acid production, causing recurrent ulcers and diarrhea, diagnosed by a paradoxical rise in gastrin during a secretin stimulation test, since secretin normally suppresses gastrin. The gastrointestinal tract isn't just a digestive tube, it's the largest endocrine organ in your entire body, and 5 hormones dominate the exam landscape. Gastrin, from G cells in the antrum, responds to peptides and distension by driving acid secretion and mucosal growth. Secretin, from S cells in the duodenum, responds specifically to acid below pH 4.5, and its primary job is triggering pancreatic bicarbonate release to neutralize that acid. Think of secretin as the duodenum's emergency neutralizing response. Cholecystokinin, from I cells, responds to fats and proteins by driving pancreatic enzyme release and gallbladder contraction. This is exactly why a fatty meal triggers biliary colic in someone with gallstones. Motilin, from Mo cells, is released during fasting and drives the migrating motor complex, sweeping residual debris through the gut roughly every 90 minutes. And this is the exact mechanism erythromycin exploits as a prokinetic, since it mimics motilin at its receptor. Finally, GIP, from K cells, responds to oral glucose and fat by triggering insulin release, the incretin effect. This single concept explains why oral glucose produces far more insulin than the same glucose given intravenously, and it's the entire pharmacological basis behind modern GLP-1 agonists like semaglutide, now widely used for diabetes and weight management. 2 enzyme highways run through your gut simultaneously. The carbohydrate pathway starts with salivary and pancreatic amylase breaking starch down to smaller sugars, which are then finished off by brush border enzymes, maltase, sucrase, and lactase, sitting right on the intestinal microvilli, before being absorbed via the SGLT1 and GLUT5 transporters. The protein pathway starts with pepsin in the stomach, but the real action happens in the duodenum, where a single switch controls everything: duodenal enterokinase. This enzyme activates trypsinogen into trypsin, and trypsin then triggers a cascade, activating chymotrypsin, elastase, and the carboxypeptidases all at once. It's a beautiful fail-safe design, keeping these powerful enzymes dormant until they're safely past the stomach and pancreas. But this design has 2 classic clinical failure points that examiners love. First, if trypsinogen gets activated prematurely inside the pancreas itself, usually triggered by gallstones or alcohol, you get autodigestion of pancreatic tissue, which is acute pancreatitis. Second, if a newborn is born with enterokinase deficiency, the entire protein cascade never starts, despite a perfectly healthy pancreas, causing severe protein malabsorption and failure to thrive. One missing switch, two completely different diseases. That's exactly the kind of mechanistic link board exams are built around.
Fat absorption is the most elaborate digestive process in the entire body, and it's worth following step by step. A fat droplet first gets emulsified by bile salts and broken down by pancreatic lipase, forming tiny structures called micelles. These micelles diffuse into the enterocyte, where the fat is repackaged into chylomicrons. And here's the critical exam point. Chylomicrons don't enter the portal vein like sugars and amino acids. Instead, they're secreted into lymphatic lacteals, bypassing the liver entirely and entering systemic circulation directly through the thoracic duct. That's exactly why fat-soluble vitamins and fat-soluble drugs skip first-pass hepatic metabolism. Now, two nutrients deserve their own spotlight because of their precise absorption sites. Iron, in its ferrous form, is absorbed in the duodenum through the DMT1 transporter, tightly regulated by the hormone hepcidin. Vitamin B12 is absorbed exclusively in the terminal ileum and only after binding gastric intrinsic factor. This brings us to a beautifully testable concept, terminal ileum vulnerability. Resect or damage this segment, as happens in Crohn's disease, and you get a dual failure. Megaloblastic anemia from lost B12 absorption, plus steatorrhea and fat-soluble vitamin deficiency from failed bile salt recycling. One anatomical segment, two completely separate clinical pictures.
The liver's functional unit is the hepatic acinus, and understanding its zonal architecture unlocks several classic exam questions. Zone 1, the periportal zone, receives blood first. It's richly oxygenated and is the first to encounter both nutrients and toxins. Zone 3, the centrilobular zone, receives blood last, making it chronically low in oxygen and the most vulnerable region in the entire liver. This is precisely why ischemic injury and paracetamol toxicity strike Zone 3 hardest. By the time blood reaches there, oxygen and detoxifying capacity are already exhausted. Beyond detoxification, the liver runs a continuous recycling loop called the enterohepatic circulation. Cholesterol is converted into primary bile acids by the enzyme CYP7A1, secreted into the gut to emulsify fat, and then an astonishing 95% of those bile salts are reabsorbed in the terminal ileum via the ASBT transporter and shuttled straight back to the liver. This efficient recycling explains why bile acid sequestrant drugs work by deliberately interrupting this loop. And when this system fails, when bile becomes supersaturated with cholesterol relative to bile salts, gallstones form. Remember the classic risk profile, the 5 Fs: fat, female, fertile, 40, and family history.
Bilirubin metabolism is a 3-station journey, and knowing where the blockage occurs tells you exactly what kind of jaundice you're dealing with. Station 1, macrophages break down hemoglobin into unconjugated bilirubin, which is water insoluble and travels bound to albumin. A block here, meaning excess hemolysis, is prehepatic jaundice. Station 2, the liver's UGT1A1 enzyme conjugates bilirubin, making it water-soluble. A block here is hepatic jaundice, from hepatocyte injury or enzyme deficiency. Station 3, conjugated bilirubin travels to the intestine and kidney, becoming stercobilin in stool and urobilin in urine. A block here, obstruction, is post-hepatic jaundice, producing the classic combination of pale, acolic stools and dark urine, because conjugated bilirubin backs up into the bloodstream and spills into urine instead of reaching the gut. 2 genetic conditions sit squarely at Station 2 and are exam favorites. Gilbert syndrome is a mild UGT1A1 mutation causing harmless, fluctuating jaundice during fasting or illness, extremely common and requiring no treatment. Crigler-Najjar syndrome type 1 is the opposite extreme, a complete absence of UGT1A1, causing severe unconjugated hyperbilirubinemia and kernicterus, a life-threatening neurological emergency in newborns unless treated aggressively. Same enzyme, same pathway, vastly different outcomes depending on severity.
Your gastric lining survives a constant acid bath through layered defenses, and two well-known attackers consistently break through them. NSAIDs inhibit COX-1, depleting the protective prostaglandins that normally drive mucus and bicarbonate secretion. Strip away that shield, and acid starts eating into the stomach wall itself. Helicobacter pylori takes a different approach, using its urease enzyme to neutralize acid locally while directly destroying the mucus layer, making it the leading infectious cause of peptic ulcers worldwide and a recognized Class 1 carcinogen for gastric cancer. Meanwhile, much further down the tract, your colon runs an entirely different kind of defense system, a living ecosystem of trillions of bacteria that ferment dietary fiber into short-chain fatty acids. Among these, butyrate stands out, supplying 60 to 70% of the energy that colonocytes need to survive, while also exerting anti-inflammatory effects. Disrupt this ecosystem with broad-spectrum antibiotics, and you create a dangerous vacuum. Clostridioides difficile, normally kept in check by healthy flora, seizes the opportunity to overgrow, releasing toxins A and B that destroy the colonic mucosa and trigger severe, sometimes life-threatening pseudomembranous colitis. Two barriers, two very different mechanisms, but both reveal how fragile the gut's protective systems really are.
Three malabsorption syndromes are constantly compared against each other on exams, and the differences are entirely mechanistic. Celiac disease is an autoimmune reaction to gliadin in genetically susceptible people carrying HLA-DQ2 or DQ8, causing villus atrophy and a dramatic loss of absorptive surface area. It's diagnosed with anti-tissue transglutaminase IgA antibodies and treated with a strict, lifelong gluten-free diet. Small intestinal bacterial overgrowth, or SIBO, works completely differently. Bacteria that shouldn't be there compete for vitamin B12 and deconjugate bile salts, crippling fat absorption without ever damaging the mucosa itself. It's diagnosed with a hydrogen breath test and treated with the antibiotic rifaximin. Short bowel syndrome is purely a numbers problem. When less than 100 centimeters of small bowel remains after resection, there simply isn't enough absorptive surface left, regardless of how healthy that remaining tissue is, requiring parenteral nutrition or the GLP-2 analog to deuglutide. And don't forget the great osmotic exception, lactase deficiency, the most common enzyme deficiency on the planet. Undigested lactose pulls water osmotically into the colon and ferments into gas, causing bloating and diarrhea, but critically with absolutely no structural mucosal damage, unlike celiac disease. Same symptom, completely different mechanism.
4 structural emergencies recur constantly across every licensing exam, and each has a single, unmistakable buzzword. Intussusception is bowel telescoping into itself, almost always in infants between 6 and 18 months, typically triggered by a Peyer's patch acting as a lead point, producing the unforgettable red currant jelly stool and treated by air enema reduction. Volvulus is bowel twisting around its own mesentery, most often at the sigmoid colon in elderly adults, recognizable by the coffee bean sign on X-ray. Though in neonates, a midgut volvulus is a true surgical emergency requiring Ladd's procedure. Meckel's diverticulum follows the rule of twos. It affects 2% of the population, sits about 2 feet from the ileocecal valve, measures roughly 2 inches long, and contains 2 types of ectopic tissue, gastric and pancreatic. That ectopic gastric mucosa secretes acid into unprotected bowel, causing painless rectal bleeding in children. And finally, Ogilvie syndrome is the great imposter, massive colonic dilation that looks exactly like a mechanical obstruction on imaging, but there is no physical blockage at all. It's purely a failure of motility. And remarkably, it responds to neostigmine, a drug that floods the enteric nervous system with acetylcholine to force the colon back into action.
When portal pressure rises above 10 millimeters of mercury, blood that can no longer flow forward through a scarred or cirrhotic liver is forced backward into smaller vessels never designed to carry that volume. And this single concept explains an entire constellation of clinical findings. At the lower esophagus, this backflow creates esophageal varices, the single most dangerous site, since rupture causes massive, life-threatening hematemesis. At the umbilicus, it reopens embryonic paraumbilical veins, producing caput medusae. At the anal canal, it produces hemorrhoidal varices. This naturally divides gastrointestinal bleeding into two clinically distinct categories. Upper GI bleeding, occurring above the ligament of Treitz, presents as hematemesis or melena, with peptic ulcer disease as the leading overall cause. Lower GI bleeding, below that same landmark, presents as hematochezia, with diverticular disease and colorectal cancer dominating in older adults. One more high-yield systemic fallout deserves mention here: carcinoid syndrome, where metastatic gut tumors flood the bloodstream with serotonin, producing diarrhea, flushing, and damage to the right-sided heart valves, since serotonin is normally cleared by the liver and lungs before reaching systemic circulation. It's diagnosed with a 24-hour urine 5-HIAA test and managed with octreotide. Now, let's pull every thread together. At the center of everything sits the brain-gut axis, coordinating four interconnected systems: the neuromotor system driving peristalsis, the secretory and acid control system, regulating what gets released and when, the hepatobiliary engine, processing and recycling bile, and the absorptive and vascular network, pulling nutrients into the bloodstream. None of these systems work in isolation. They constantly signal back and forth through hormones, nerves, and shared blood supply. And here is the single most important exam strategy we can leave you with. Board questions are built by isolating one disruption and asking you to trace its consequences. One failed enzyme, enterokinase, and the entire protein digestion cascade collapses. One blocked pump, the hydrogen-potassium ATPase, and acid secretion stops cold. One resected segment, the terminal ileum, and you get both anemia and fat malabsorption simultaneously. Mastering the gastrointestinal system isn't about memorizing a list of organs. It's about fluidly connecting anatomy, biochemistry, and physiology, so that when an exam isolates one single failure point, you can immediately trace the entire downstream cascade with confidence. That is gastrointestinal mastery, and that is exactly what will carry you through USMLE, MRCP, PLAB, AMC, and MBBS examinations. Please like, comment, share, and subscribe to Studious for more high-yield content like this.